other PGs to know how this is going to be managed. So as you rightly said, I also start with what is the pathophysiology of brain death. And here what is the cause for the various derangements that are happening. The main thing is, first thing they are thinking about, the first change to happen will be hypothermia. All brain dead patients, they become hypothermic very easily because of the hypothalamic damage, reduced metabolic rate, vasodilatation, and heat loss. Invariably, if not prevented, it will lead to hypothermia. The second system that is going to be affected is the cardiovascular system, which will be in the form of hypotension. And because of vasoplegia and hypovolemia, reduced coronary blood flow, myocardial dysfunction are the causes for that. And posterior pituitary damage will happen because it is connected with the hypothalamus, and it will cause diabetes insipidus. I think in the last class I discussed more about diabetes insipidus. The two varieties, the neurological or cranial and nephrogenic. And DAC can happen because of the tissue factor release, which will lead to coagulopathy. And catecholamine strong myocardial damage, reduced coronary flow, can lead to arrhythmias also. And acute blood volume diversion or capillary damage lead to pulmonary edema. So these 6 things are very commonly happening, starting with the hypothermia, hypotension, DA, DAC, arrhythmias, and pulmonary edema. Now, individually seeing how the cardiovascular issues are occurring, the raised intracranial pressure leads to a Cushing's reflex, which stimulates the release of epinephrine up to 1,000 times normal levels. So the so-called catecholamine strong or catecholamine surge is because of the Cushing's reflex, which releases epinephrine. And this can lead to subendocardial ischemia, arrhythmias, pulmonary edema, or finally decrease in cardiac output along with hypertension because of the vasoconstriction. Once the reflex subsides slowly, it will be a reactionary reflex immediately occurring, but as the reflex subsides, the secretion of epinephrine levels go down, becomes subnormal, and the underlying decrease in ejection fraction becomes unmasked, causing severe hypotension. So there will be hypertension followed by severe hypotension in the initial phases of brain death. So we have to watch out for this. And once hypotension has set in, the posterior pituitary stops secreting the vasopressin and the urine output increases, which will not matched by intravenous fluid, will lead to very severe hypovolemia. And if it is corrected externally with administered vasopressin or its analog, can lead to hypovolemia, aggravating the hypotension and systemic hypoperfusion. So it is a very tricky situation where you have to manage this reduction in epinephrine level by proper assessment and treatment. And if hypotension is not corrected, it can lead to organs being rendered unusable. So prolonged hypotension for more than 6 hours in a brain dead patient, the organs will not be suitable for donation. So even if the relatives give consent to harvest the organs, it is the way we manage them in ICU is very important to get the good functioning organs for donation by the proper management of the hemodynamic stability. So main emphasis on replacing vasopressin secreted by the posterior pituitary and methylprednisolone in supraphysiological doses. He said 15 milligram per kg body weight. Sometimes they give even up to 30 milligram per kg body weight. Has been associated with decreased extravascular lung water, decreased levels of inflammatory markers, and increase in organ retrieval. That is, the organs function better with this supraphysiological doses of methylprednisolone. And intravenous T3 leads to improvement in catecholamine responsiveness and consequently better organ perfusion. So these two drugs are considered very, very important if the hypotension has been there for quite some time and it has been restored by replacing vasopressin. These two drugs should not be forgotten. That is administration of methylprednisolone and T3 to maintain normal perfusion so that the organs harvested are in a good functional state. And low dose insulin infusion aids in the avoidance of hyperglycemia. Okay? And general treatment principles are hemodynamic management, crystalloids first choice, avoid overhydration also, vasopressors as clinically indicated, and lung protective ventilation to prevent barotrauma and de-recruitment. Prone position if poor gas exchange is there despite optimization of your ventilatory settings. Prevention of complications like infections, DVT, and low molecular weight heparin can be used for DVT prophylaxis if there is already no coagulability due to the reasons I told you. DAC, if it's not set in, you can use this. And maintain normothermia, metabolic control. This will lead to endocrine therapy, which has to be tailored for diabetes insipidus, thyroid hormone, hydrocortisone. So this one slide will tell you or to help you to remember what are all the points that you have to keep in mind. So more than that, everything has been nicely told by Vidya, so that I will stop with this without wasting much time. Okay. Right.